Welcome to the second day of the 2020 annual meeting of the Thai Gynecologic Cancer Society, TGCS. My name is Kittipat Jarenkwan, and I'm going to be a moderator for today's morning session. The first session is a Fellows Research presentation, which is organized by the TGCS Scientific Committee and the RTCOG Fellowship Training Committee. The objective of this session is to provide our newly graduated gynecologic oncologists the chance to present the results of the research they have conducted over the course of their fellowship. This would also be a great opportunity to keep our society members updated on fellows' research activities. As usual, according to the fellowship training's internationalization policy, this session will be conducted entirely in English. Just a quick overview before we start. We have 11 presenters today. Each presenter will be given 8 minutes for both presentation and Q&A. So after the first presenter finishes, we will move on directly to the next presenter. So I'd like to start with Dr. Lalita Khosit Warakitgun from Chulalongkorn University, please.
Good morning, everyone. My name is Lalita Khosit Warakitgun from Chulalongkorn Hospital. Today, I would like to present my research, and the topic is sexual health status of gynecological cancer survival in King Chulalongkorn Memorial Hospital. Let's start from with the background. In Thailand, the gynecological cancer was nearly about 25% of total cancer, and the cervical cancer was about 14%, endometrial cancer about 5%, and ovarian cancer about 3%. And the current advancement in gynae cancer treatment offer the better oncological outcome and improve the 5-year survival rate as high as 65%. And this survival may live with the consequence that may occur after cancer treatment. I have interested in the quality of life of our survival and focus to the sexual health. So I want to evaluate the sexual health status of the gynecological cancer survival and to identify the benefit of sexual health counseling. I set a cross-sectional study that starts from June 2019 to February 2020. The participants were recruited from Gyne-Onco Clinic at Chulalongkorn Hospital, and I include the inclusion criteria was the sexual active patient before diagnosis of gynae cancer, and their age were greater or equal to 18 years and able to understand Thai language. For the patient who refused to do the questionnaire or had any active psychiatric disorder will exclude from my study. I create a questionnaire to use as a tool to assess the sexual health status of gynecological cancer survival. My questionnaire has 2 parts. First part of the questionnaire was to get the general information and sexual health status, and the second part was the sexual health problem in 14 items. Each item rating scale were scored from 1 to 5, the rating by severity of the problem. And the questionnaire were answered by the patient themselves in a private room at the OPD of Gyne-Onco Clinic and Radiotherapy Clinic. After finish the questionnaire, I will discuss about the disease, the complication, and or any problem with my patient, and give them some information, some counseling, and get the feedback about the questionnaire from them. And the questionnaire will perform again in 12 weeks interval. The difference between first and second answer will be analyzed. Let's move to the result. There are 105 participants were recruited in my study. The mean age was about 50 years. And about the cancer disease, there were ovarian, fallopian tube, and peritoneal cancer about 40%, and cervical cancer about 30%, and endometrial cancer about 15%. 61 patients had sexual health concern or sexual health problem, and 62 patients have resumed sexual activity after complete the treatment with mean duration about 9 months. And more than half of these women in the study never received the sexual health information from doctor. About the sexual health status of gynecological survival, there are menopausal symptoms about 50%, and 10% of them get the hormonal replacement therapy. About the source of the sexual health information, about 40% of them get the counseling from physician or nurse, and other 40 get the information from internet, from magazine or books or their friends, and as high as 30% never get this information. And I analyzed about the factor that relate to the resumption of the sexual activity and found that the patient who has age less than 50 and who be the premenopausal status before treatment will resume the sexual activities. And the requirement for health information and counseling was significant increase in both resume and never resume sexual activity group. So when we talk about the quality of life of our gynecological cancer patient, there are only few studies of sexual health in Thai gynae cancer survival, and my study evaluate about this aspect. And the data of the study may useful for counseling or surveillance this patient. I think this is the strength and benefit of my study. But my study still have the limitation about the sample size per each disease was too small, and I didn't get the data from participants' partner that may affect the outcome of my study. So for further study, I think should explore the detail of each sexual health problem and discuss with the multidisciplinary team. For the conclusion, more than half of gynae cancer survival have sexual health concern and need sexual health counseling. So we should discuss about this aspect to our patient to improve the quality of life of them. Thank you for your attention.
Thank you very much. I think we can take one or two quick questions from the audience, please. Yeah, I think sexual health is actually one of the most important but also overlooked problems in patients who suffered from gynecologic cancer. And this study has once again emphasized the importance of recognizing this problem in our patients. So I'd like to thank you very much, Dr. Lalita from Chulalongkorn University. Before you go back, please stop by at the side desk to pick up the souvenir as a token of appreciation from the TGCS. Right there. Thank you very much. I will also move right on to the next presenter, which will be Dr. Narathasapon Likitdi from Khon Kaen University, please. Dr. Narathasapon, I think this study is the one that he presented in at the ASCO meeting in Seoul. So if you are ready, please start.
Okay, thank you very much, Professor Kittipat, and good morning, everyone. It gives me great pleasure to speak to you today. I'm going to talk about why it's important to assess knowledge and attitude of Thai women regarding HIV infection and vaccination on research into this topic. I have no conflict of interest to discuss. As we know before, sexually acquired infection with highly HPV is a precursor to cervical cancer and precancer. Various educational interventions such as the LIDAR Social campaign, health educational websites have been implemented to increase HPV awareness and the rate of HPV infection and HPV vaccination. Previous studies have found that knowledge and attitude are induced factors, and these factors were associated with the success of the cervical cancer prevention programs, and make them a very important issue to consider when designing a health educational programs. However, some studies reported that the level of knowledge has been found to vary by the regions. So, this study was conducted to assess the level of knowledge, attitude, and to understanding the factors associated with the level of knowledge of Thai women by using the Facebook as the tool for the nationwide recruitment. And this is a cross-sectional study was conducted by using the open e-surveys via Facebook to assess lesson and knowledge, attitude regarding HIV infection and vaccination. We applied the checklist or the reported result of the Internet e-survey called Cherries to conduct and report our results. Thai women aged between 18 to 26 years of age were invited to participate in this study through the target advertising on Facebook from May 17 to June 14, 2019. Eligible participants were asked to click on the link to read the consent form, and after informed consent was obtained, participants would automatically receive a link to the electronic questionnaire via email. The advertisement survey announcement was posted on our Department official fan page, Department of Obstetrics and Gynecology, Faculty of Medicine, Khon Kaen University. The specific targeted option was selected for example, female aged between 18 to 26 years old who live in Thailand via the Facebook Advertisement Manager or Facebook Ad Manager. The questionnaire consists of 3 pages covering the personal data, knowledge regarding HIV infection and vaccination, and attitude toward HIV infection and vaccination too. If the page of the questionnaire was incomplete, the participant was not allowed to continue to the next pages. And to prevent duplication entry from the same user, our e-survey registration was designed not to allow and to access from the same email address more than once. Descriptive statistics including numbers, percentage, and minutes with the intercontact length were used. Univariate analysis were carried out to identify factors particularly related to HIV infection and vaccination. Knowledge including like the region of residence, occupation, education level, monthly income, religion, sexual behavior, and the variable with the central significance in univariate analysis were then included in stepwise multivariate analysis too, and to determine which factors were independent associated with knowledge. Here it is the results. A total of the 1,175 participants were recruited. Approximately 3/4 were aged between the 20 to 26, and most of the participants resided in the north-eastern region of Thailand, followed by the central region, northern, southern, and Bangkok specifically. And these demographic characteristics did not differ from the distribution specified by the National Bureau of Statistics of Thailand. More than half of participants have a bachelor degree, and approximately 60% had a monthly income below the national average household incomes. And almost half has a sexual partner, and around 90% were unvaccinated against the HPV. This slide shows the estimate score with regard to HIV infection and vaccination. Most participants in our study have some misunderstanding about the HPV. Only 12% know that HIV infection usually have no signs and symptoms, and nearly 50% thought that condom use can be free protection against the HPV. But some aspects seem to be well understood. For example, approximately 80% of the participants know that HIV can be transmitted via sexual intercourse, and around 77% know that HIV infection is the main cause of cervical cancer. This slide shows the result of multinomial certification and the factors that were individually associated with the poor level of knowledge, including educational, lower than university, lower monthly incomes, being Christians, and having a sexual partner, and being unvaccinated against the HPV. And this slide shows the participants in this study have the good attitude toward HPV infection and vaccination. We found that approximately 46% of Thai women who participate in this study were defined as having a poor level of knowledge regarding HPV infection and vaccination, and the factors associated with HPV knowledge were education level, family incomes, had a sexual partners relation, and vaccination status. The study from the German and Australia found that over 90% and total 63% of the participants were aware of HPV. However, in study in South America found that only the 55% of the mothers have ever heard about the HPV. And two studies in China found that approximately 45% of women in mainland China have ever heard about HPV, but around 30% in Western China. Some misunderstanding about the HPV and some aspects seem well understood. Our findings were consistent with the previous study. And our study found that low educational level, low monthly incomes, and having a sexual partner were significantly associated with low HPV knowledge. And this consistent with the previous study have reported that the educational level, socioeconomics, and employment status were positively associated with the percentage of correct answers. Regarding to the association between place of the residence and level HPV knowledge have been found from the previous study, our result failed to confirm this finding, and because it's not significant after we adjust from the O2 variables. This is the first study that focused on knowledge and attitude regarding HPV infection and regarding HPV using a nationwide social media survey in Thailand. Our study was able to liquid a large sample size covering all of the different regions of Thailand. However, some limitation is that the result of this survey cannot be validated as they were based on the self-reporting data. Our result indicating that women who have the low educational backgrounds, low socioeconomic status, and those who were unvaccinated against the HPV were more likely to have the low level of HPV knowledge. And so, this group of women should therefore be targeted to improve the effectiveness of the cervical cancer program strategy. Thank you very much. ขอบคุณครับ
Yes, thank you very much. I think we have time for one quick question, please, from the audience. Yeah, I think this is the very interesting research. This is also an example of how to make a good use of social media. I think your experience with this project will be very beneficial for your future project as the faculty administrative officer taking care of the student affair. So thank you very much, Dr. Narathasapon, and please do not forget to take the small souvenir from the president as a token of appreciation. Thank you very much. I will move on to the next presenter, which is Dr. Jiamjila Intarangsi from Ratchavithi Hospital.
Good morning, ladies and gentlemen. My name is Jiamjila Intarangsi. I'm from Ratchavithi Hospital. First of all, I would like to thank Thai Gynecology Cancer Society for giving the opportunity to me for presenting our data today. This is about predictive factor for endometriosis-associated ovarian cancer. I have nothing to disclose. Endometriosis is a common gynecological condition, occur in 5 to 15% of premenopausal women and 3 to 5% of postmenopausal women. Ovarian endometriosis engender a management dilemma of conservative or radical treatment for many patients. This is because it can become malignant, especially into type 1 epithelial ovarian cancer, and we call this endometriosis-associated ovarian cancer. The criteria for diagnosis of this condition has been proposed by Sampson and Scott. From a systematic review, many variables include age, parity, menopausal status, and imaging findings significantly associated with increased risk of epithelial ovarian cancer in ovarian endometriosis. Goff developed a symptom index to trigger screening for ovarian cancer and found that pelvic abdominal pain, increased abdominal side bloating, and difficult eating, feeling full were significantly associated with diagnosis of ovarian cancer. If patient experience of any those symptoms greater than 12 times per month but within the past 1 year. Moreover, serum biomarkers such as cancer antigen 125 or human epididymis protein 4 are also the important tool to discriminate ovarian cancer from benign condition. Some unresolved findings are also strongly associated with cancer, for example, presence of solid component or increased vascularity. So, we create a study aiming to identify the predicting factor for ovarian carcinoma arising in the background of endometriosis or endometriosis-associated ovarian cancer. After obtaining approval of the Institutional Review Board of Rajviti Hospital, a nested case control study was conducted in a cohort of women presenting with adnexal or ovarian cyst or tumor who underwent elective surgery at Rajviti Hospital during January 2014 to December 2018. Medical record, including clinical symptoms, ultrasound findings, tumor marker, and multimodal tests. Sample size was calculated based on the formula for comparing independent proportion with a 1:4 ratio. Given an expected dropout rate of 20% of the estimated sample size of 42 cases and 168 control was finally required. Statistical analysis using Stata 15. Totally, there were 2,156 women presenting with adnexal or ovarian cyst or tumor who underwent elective surgery. 1,598 women were benign ovarian disease and 558 women were ovarian cancer, including borderline ovarian tumor. Histologically proven EAOC were identified for 43 women. 3 patients were excluded due to incomplete sonographic and serum biomarker data. 40 cases were finally included in the present study. Patients with OE were matched to control cases in 1:4 ratio from each corresponding month. This is baseline and clinical characteristic. Women with EAOC were significantly older and more postmenopausal status than OE. For clinical symptoms, EAOC women had significant more palpable abdominal mass, more abdominal bloating, more loss of appetite, and more loss of body weight, but less history of secondary amenorrhea. And EAOC patients have significantly more positive cough symptom index. Ultrasound parameters were significantly different between both groups, with significant large size, more solid component, and more ascites in EAOC group. For operative outcome and histopathology, the majority of EAOC women were diagnosed with stage 1 disease. Clear cell and endometrioid carcinoma comprise to the majority of histologic subtypes. Comprehensive surgical staging was performed in 95%, with optimal surgery 85%. The overall performance for distinguished EAOC from OE using serum HE4 LOMA and IMI score were significantly higher than serum CA125. LOMA score and serum HE4 exhibited the best performance. Univariate analysis for the predictive factor for EAOC found that older age, postmenopausal status, positive cough symptom index, palpable abdominal mass, loss of body weight are significantly positive predictive factor, while presence of secondary dysmenorrhea is significant negative predictor. Larger cyst size, ultrasound finding of solid component, ascites, and higher serum HE4 LOMA and IMI score were significant positive predictive factor on univariate analysis, while ultrasound finding of bilaterality is significant negative predictive factor. Significant predictive factors from multivariate analysis are age 45 years and older, ultrasound finding of cyst size greater than 10 cm and have solid component, and serum HE4 more than 7 dpml. The predictive score from EAOC was developed from the final multivariate model using AOR. The point given to each predictive factor were 1 point to age 45 years and older. Ultrasound finding of cyst size more than 10 cm and finding of solid component 2.5 point to serum He4 more than 70 pml. Using cutoff point 2.5, this predictive score shows sensitivity 95% and specificity 81.9%. The discussion meta-analysis from Hyman found that prevalence of EAOC wide range 2.0 to 17.0% of women with OE and 3.4 to 52.6% women with ovarian cancer. This present study found that incidence proportion of EAOC 5.7% in women with OE and 7.7% in women with ovarian cancer. This study found that women with EAOC were significantly older and were more postmenopausal status and had more symptoms of palpable abdominal mass, abdominal bloating, loss of appetite, loss of body weight than those OE patients. Although cough symptom index was significantly associated with EAOC in this study, this index has sensitivity 52.5% and specificity 75.6% for discriminating between EAOC and OE. This index performed lower specificity than original study. Most of EAOC cases were type 1 EAOC. This netted case control study discovered that the predictive factor for EAOC among women with OE are age older than 45 years, ultrasound characteristic of cyst size more than 10 cm, solid component and serum He4 above 70 pml. Increasing age is a key factor associated with EAOC in study of Okabayashi. The strength of this study was that the decreased measurement bias due to preoperative serum biomarker and pelvic ultrasonography was routinely investigated before surgery. The limitation of this study were the inherent nature of retrospective study, the relatively small number of case groups, and the participants from a single tertiary hospital. Clinical useful the predictive model from this study can be assessed in the prospective study examining the clinical, serological, and imaging findings in women with ovarian endometriosis prior to surgery, and validating this model. The predictive score of 4 significant factors provide a tool to aid in the risk assessment and appropriate management in women presenting with endometriosis. Consideration about surgical intervention and consultation of gynecologic oncologists should be amenable for ovarian endometriosis patients who have serum He4 level higher than 70 pml or who are older than 45 years old and have a cyst larger than 10 cm with solid component. Conclusion: this study suggests that significant predictors for EAOC include age, ultrasound cyst characteristic and serum biomarker level, and the high risk for malignant transformation of ovarian endometriosis are women aged 45 years and older, cyst larger than 10 cm with solid component and serum He4 level higher than 70 pml. The author wish to thank Assistant Professor Sombun Sornskulat, Head of Department of Obstetrics and Gynecology, Raviti Hospital for permission in the reporting to present study today, and Raviti Hospital for Ghent. Thank you.
Yeah, thank you very much for your nice presentations. Actually, I have a lot of questions to ask, but we have run out of time. So please do not forget to pick up your souvenir from the president. And I'd like to move on to the next presenter, which is Dr. Ponsiri Ekpoom from Sinakrin Virod University. Please.
Good morning, Chairman and Co-Chairman. My name is Ponsiri Ekapum from Srinakari Miller University. Today, I would like to present the paper Recurrence of High-Grade Cervical Intraepithelial Neoplasia after loop electrosurgical excisional procedure with positive margin. I'm going to the introduction. The high-grade cervical intraepithelial neoplasia are consist of SIN2 and SIN3. Conization, especially LEAP, is widespread procedure for treating a high-grade cervical lesion. The incidence of positive margin following the treatment of high-grade cervical lesion is 15 to 44%. In addition, the period found that the positive margin after LEAP was a possible risk factor for the recurrence of high-grade cervical lesion. Currently, there are no best management for this group of patients. Follow the ASCCP guideline. The choice of management includes cervical cytology follow-up and repeat excision. This study aims to find the proper management in the patient with positive margin after treatment of high-grade cervical lesion by LEAP. The primary objective was to find the risk of recurrence of high-grade cervical lesion or progression to invasive cervical cancer within 1 year of treatment of SIN2 and SIN3 patients who had a positive margin, comparing between non-repeat LEAP and repeat LEAP group of subsequent management. Okay. I would like to turn to the material and method. The study design is a prospective cohort study. The sample size calculation was done by using a formula for testing two independent proportions based on the incidence of recurrence of high-grade cervical lesion in patients who had positive margin lesion after treatment by LEAP. The expected population was 96 participants in the testing of 5% alpha error and 20% beta error. A total of 132 participants were enrolled in this study. The inclusion criteria were high-grade cervical intraepithelial neoplasia, which consists of SIN2 and SIN3 who have positive margins after LEAP treatment. The exclusion criteria were patients with history of invasive cervical cancer who had a subsequent management by hysterectomy or incomplete data such as a lot follow-up. The demographic and treatment data were collected from colposcopic record between 2007 and 2017. The patient who had SIN2 or SIN3 with positive margin after treatment by LEAP were subsequently management and follow-up at Her Royal Highness Princess Mahachakri Sirinthorn Medical Center. In this study, the patients were divided into two subsequent management groups after initial LEAP, including non-repeat LEAP and repeat LEAP group. In the repeat LEAP group, patients underwent repeat LEAP within 8 weeks after initial LEAP treatment. In the birth group, patients were enrolled up using cytology follow-up every 4 to 6 months. If abnormal cytology was found, colposcopy and cervical biopsy was done to rule out the high-grade cervical lesion recurrence. Now I would like to look at the demographic data. The total number of patients who had SIN2 or SIN3 preceding initially with positive margin were 132 patients. The patients were divided into two subsequent management groups consisting of 67 and 65 patients in non-repeat LEAP and repeat LEAP group respectively. The demographic data consists of age of patient, pap smear result, LEAP information, and follow-up duration that shown in Table 1. It's not differentiated in the birth group of management. The characteristic of repeat LEAP group was depicted in Table 2. In the repeat LEAP group, the mean duration of initial LEAP to repeat LEAP was 6 weeks. The history of repeat LEAP tissue was found to be residual high-grade cervical lesion in 43.1%. The summary recurrence of high-grade cervical lesion was displayed in Table 3 that found in 19 patients, 14 in non-repeat LEAP and 5 in repeat LEAP group. Such lesions include SIN2, SIN3, squamous cell carcinoma, and adenocarcinoma. After bivariate analysis of variable subsequent management group, age, colposcopic evaluation, location of involved margin, maximum diameter of leaf tissue were included in the multivariate analysis. As presented in Table 4, the variable associated with the recurrence of high-grade cervical lesion by logistic regression analysis were group of subsequent management and age. Non-repeat leaf group was a risk factor of the recurrence of high-grade lesion. The adjusted odds ratio is 3.364 and the p-value is 0.033. Likewise, the age more than 50 years old was found to be potential risk factor too. I would like to turn to the discussion. In this study, those patients who had positive margin of high-grade lesion after leaf treatment and had repeat leaf, it found that the residual of high-grade lesion remained around 43.1%, compared with the previous study was 32 to 53%. According to the previous study, the follow-up of high-grade cervical lesion found that SIN2 had a change of persist of disease by 35% and progression by 12%. Moreover, SIN3 may persist by 56% and progression to invasive carcinoma by 12%. From this study, it found that the patient had positive margin of high-grade lesion by leaf, and those patients who had no repeat leaf will cause a risk factor that lead to high condition of recurrence of high-grade lesion than the patient that repeat leaf in comparison. In explanation, the non-repeat leaf group may have a change to have a remaining of high-grade lesion more than the repeat leaf group. However, the repeat leaf for this group may reduce the risk of recurrence of high-grade lesion, but it's necessary to be aware of the side effect of leaf method in patient fertility needs, such as preterm delivery and other pregnancy complications. To conclusion, non-repeat leaf was a risk factor of recurrence of high-grade cervical intraepithelial neoplasia or invasive cervical cancer in SIN2 or SIN3 patients who had positive margin after initial leaf treatment. Okay, thank you.
Thank you very much. I would like to take one quick question from the audience, please. Yes, Ajahn Karun, please.
Thank you for a very interesting paper. You said that the margin positive is 49.2%, right? And around 65 cases. Can you tell us that when you say positive margin, is positive inner margin or endocervical margin or ectocervical margin? This is important because it's the way we do the leaf. You know that the depth is as important as the margin. Please.
In my study, we collect the position of the margin, endocervical, ectocervical, or both, but in the bivariate analysis, it's not affect to the recurrence in this study.
So you done record. It is inner margin or extocervical margin.
Yes.
It should be record.
In my study, it record in the demographic data.
Can you show us?
Yeah.
I haven't seen it. So it takes time.
Yeah, I think it's okay. Did you have a chance to do the subgroup analysis on the margin status? You can give us the data, just a brief overview of the data. The endocervical or ectocervical positive margin.
Okay, in my review literature, the position of positive margin such as endocervix, ectocervix is affect the recurrence of high-grade lesion, but in the study is not affect.
So the rate of recurrence high cell was not different between the endocervical and ectocervical positive margin, right? In your study,
Yes,
there was no
yes.
difference between this subgroup, right?
Yes. In this study, the effect is the age and the group of management consists of repeat lead and non-repeat lead.
Yeah. So only age and whether or not you do the repeat the procedures, right?
Yes.
Yes.
Right, it is not the effect, but my point is that when we doing the leap, we concerned about the depth of the leap, right? And that it's if we have the subgroup analysis, it will give us some more knowledge about
Yes.
that.
Definitely.
Right.
Yes.
Okay, that's matter. Thank you.
Thank you.
Thank you very much. So I'd like to move on to the next presenter, which is Dr. Pishamon Sukhasem from Prince of Songkla University.
Good morning, ladies and gentlemen. I would like to present my title as Prevalence Predictive Factor and Nomogram of Residual Disease Following Cervical Cancer for Adenocarcinoma in situ. Adenocarcinoma in situ of cervix, or AIS, is recognized as a precancerous lesion of cervical adenocarcinoma. Normally, the incidence of AIS is lower than square mass abnormality. Recently, the incidence of AIS tends to relatively increase compared to square mass cell abnormality. According to ASCCP guideline, the standard treatment of AIS is hysterectomy. However, fertility preservation surgery is the other choice of treatment for women who had fertility concern. Over the decade, AIS has tended to occur in the younger women. Nowadays, women tend to delay childbearing compared to the past. Well, fertility-sparing surgery is considerably challenged in these women. The risk of residual disease after the procedure and coexisting adenocarcinoma should be considered as well. From the previous study, the risk of residual disease is related to age more than 35 years, persistent abnormal pap smear result, post-cone margin, presence of AIS in endocervical keratine tissue, smaller cone volume, and an invisible squamous columnar junction on colposcopy. However, these findings were unclear. The primary objective of this study is evaluation of prevalence of residual disease after colonization in AIS women. The secondary objective is evaluation of predictive residual disease and constructed a nomogram for predicting residual disease. This study is a retrospective study that includes patients diagnosed AIS from cervical colonization who underwent subsequent hysterectomy from January 2004 to December 2018. The exclusion criteria was coexisting cervical cancer, complete cervical cancer treatment, and pregnancy. Finally, the 83 patients were included in this study. The chi-square Fisher exact tests were used for univariate analysis and logistic ligation model for multivariate analysis. Then, these factors were used to construct the nomogram for predictive residual disease. Result: the 83 patients were included. The mean age of patients was 47 years old. About 3 of 4 AIS were diagnosed by LEAP. Residual disease after colonization was present in 25 women, who was 6% had invasive adenocarcinoma. The other residual disease identified was 20% of pure AIS, 2.4% of AIS with coexisting CAN, and 2.4% of CAN. The factor associated residual disease in the subsequent hysterectomy specimen from univariate analysis was age, menopause status, depth of Crohn specimen, coexisting CAN, margin status, and endocervical keratosis results. The multivariate analysis showed positive endocervical status and depth of Crohn specimen were the important prognostic factor. For multivariate analysis, the factors were constructed to nomogram. The internal validation of nomogram was analyzed using 1000 boosted method. The mean absolute error was 0.039 and concordant index was 0.85. Discussion. This study found 1 of 3 residual disease in hysterectomy specimen, which occurred concurred with finding of previous study. The rate of residual disease in positive ectocervical margin was slightly higher than other, which could be because of the mean depth of specimen was 8 mm, that less than ASCCP recommendation of AIS. Overall, the rate of adenocarcinoma on subsequent hysterectomy among our AIS women was as similar as previous study. All coexisting adenocarcinoma occur in patients with positive margin. The present study identified endocervical margin status and depth of Crohn margin as the independent factor associated residual disease after colonization, 22 and 84 respectively. The present study had reported the association between endocervical margin status and residual disease, which consistent with this study. Moreover, some study reported as same as recent study, which show the coexisting adenocarcinoma was found in patients with positive only endocervical margin. This may be explained by the fact that glandular abnormality likely occur in an extent into the endocervical canal rather than an ectocervical area. The greater Crohn depth signifies a better chance to remove glandular lesion located in endocervical canal, as well as decreased risk of residual disease. Historically, many studies have shown that CKC was associated with lower rate of positive margin than LEAP. However, many retrospective studies, meta-analysis, and our findings from this study shown that the rate of residual disease after colonization between CKC and LEAP in AIS women were not significantly different. So this result provides evidence of emphasize the importance of obtaining an adequate Crohn depth regardless of mode of excision help to reduce risk of residual disease. This study reported the first predictive nomogram attempt to evaluation the risk of residual disease after colonization in AIS women based on characteristics of individualized colonization specimen. The nomogram may decrease the risk of glandular abnormality following sparing surgery and late inadvertent hysterectomy for occult invasive cervical cancer. The strength of this study is hysterectomy specimen is used as gold standard. Predictive factors were skeletonizing use and multivariate analysis. On the other hand, the limitation of this study is retrospective nature. Some potential risk factors such as HPV infection is not available. Lastly, sample size was limited from single tertiary center. In conclusion, about 1/3 of women had residual disease. After colonization for AAS, a strong association was identified between the risk of residual disease and both depth of cone specimen and positive surgical margin, especially in case of endocervical margin. This study reported nomogram predictive individual risk of residual disease in AS patient after colonization. It provides disease-related estimation that can be used to inform the patient for treatment in the future. Thank you.
Thank you very much. I would like to take one question, please. So you use the bootstrapping technique to develop the nomogram, right? The nomogram that you develop, you use the bootstrapping technique to amplify your sample size, right? Because this is not the very common conditions, right? So do you have a plan to validate your nomogram in another population, which is the important step, right, in the development of the nomogram? Do you and your team have a plan to validate your nomogram in another population?
This nomogram is about validate only internal validation, but
internal validation,
not external validation. I compare about the data to observational. It use the program for evaluation, not use another data for evaluation.
Yeah, I think this is a very important and very interesting research questions. But I would suggest that you find a chance to test your nomogram in another populations to increase the generalizability, so you can use it in more general populations. So thank you very much for your nice presentations. The next presenters will be Dr. Pathamaporn Muenpitak from Pramukut Klau Hospital.
Good morning, everyone. I am Pathamaporn Muenpitak. I come from Pramukut Klau Hospital. Today, I would like to present about preoperative predictive factor and score for optimal cytoreduction after neoadjuvant chemotherapy in stage 3C and 4 epithelial ovarian, fallopian tube, and primary peritoneal cancer. So we will begin with the introduction part. Ovarian cancer is the 8th most common cancer among women in the U.S. Although the incidence of ovarian cancer is found at only 2.5% of all cancer among women, it has become the leading cause of death in gynecologic cancer. In Thailand, there were 3,254 cases diagnosed and 1,940 cases died from ovarian cancer in 2018. Most of the first detection found in advanced stage, with the 5-year survival rate of less than 30%. The standard treatment for advanced ovarian, fallopian tube, and primary peritoneal cancer are primary cytoreductive surgery and neoadjuvant chemotherapy followed by interval debulking surgery. There is no difference between the survival rate of these two treatments. Additionally, there is an increasing rate of optimal cytoreduction and decreasing in both intra- and post-operative complications in neoadjuvant chemotherapy. There is a higher survival benefit in optimal cytoreduction as compared to suboptimal cytoreduction. According to previous study, the preoperative prediction were created from preoperative clinical data, CA-125, radiological feature, and laparoscopic finding. Currently, there is no predictive model that can accurately predict the success of the surgery. Material and method. For the objective part, the primary outcome are to exhibit preoperative predictive factor and score based on clinical and radiological data to predict optimal cytoreduction of patients with advanced ovarian cancer, fallopian tube, and primary peritoneal cancer in patients receiving neoadjuvant chemotherapy followed by interval debulking surgery. And the secondary outcome is to compare overall survival and progression-free survival between optimal and suboptimal cytoreduction. Next, we discuss about material and method. The study was defined as retrospective cross-sectional study and approved by IRB Royal Triarmy. So, the sample size was 47 cases and the calculation was based on the study from Illinois with the other researchers. This slide shows the population criteria consist of inclusion and exclusion criteria. The collected data were clinical data level of CA-125, modified peritoneal cancer index, and time. The modified peritoneal cancer index was adjusted based on the original peritoneal cancer index by Jacot and Sugar-Baker. The small bowel region were eliminated in the modified peritoneal cancer because it was hard to detect in the CT scan assessment. The results of CT scan were first read by the radiologist, then reviewed by the gynecologic oncologist for the second time. In case of uncertain outcome, the result will be re-evaluated again. For statistical analysis, we use many tests to analyze our data. In predictive factor, we use univariate and multivariate logistic regression analysis. Then we took all of the statistically significant predictive factors to develop the score. The overall survival and progression-free survival were calculated by Kaplan-Meier analysis. The p-value less than 0.05 was considered statistically significant. Here is the flowchart of patient selection. The optimal cytoreduction group was 31 patients and the second group was 13 patients in suboptimal cytoreduction. Here are the results of our research. In patient characteristics, there was statistically significant difference in FIGO stage 4 disease, number of neoadjuvant chemotherapy cycle, CA-125 before interval debulking surgery, and modified PCI score before interval debulking surgery. There are the base cut-off number of the preoperative predictive factor in the continuous data. This table shows univariate and multivariate to predict the score for suboptimal cytoreduction. In this study, we use only multivariate results to develop the score. So, the score indicates the probability of suboptimal cytoreduction in risk group. Then the risk group were divided based on low, intermediate, and high risk. There is no statistically significant difference between the optimal and suboptimal cytoreduction groups in the progression-free survival and overall survival. Now, its discussion part. Our study found that the optimal cytoreduction rate was about 70.5% compared to previous study of about 70 to 94%. In preoperative predictive factor in this study, the first factor is FIGO stage 4. In retrospective study and meta-analysis, FIGO stage 4 did not correlate with the median overall survival in the patient whom receiving neoadjuvant chemotherapy. In our study, we found that FIGO stage 4 correlates with the suboptimal cytoreduction. The next factor is the number of neoadjuvant chemotherapy cycles. In the previous study, the number of neoadjuvant chemotherapy cycles and timing of interval debulking surgery are still debatable. However, we found that the patient who received 5 cycles of neoadjuvant chemotherapy show correlate with suboptimal cytoreduction. Another factor is the preoperative serum CA-125 level. Many previous studies show that the decline in CA-125 level before interval debulking surgery correlate with optimal cytoreduction. Similarly, our study also showed the reduction of CA-125 before interval debulking surgery less than 97% associated with suboptimal cytoreduction. Moreover, the CT scan show higher accurate but lack reproducibility and limit cost variety in different hospitals. Our research used the modified PCI score with the accuracy of 70% and found that the decreased modified PCI score before the interval debulking surgery less than 64% correspond with suboptimal cytoreduction. The scores were divided based on low, intermediate, and high risk for suboptimal cytoreduction. The past study indicate the increase in survival benefit of patients receiving neoadjuvant chemotherapy followed by interval debulking surgery with less than 1 centimeter. In our research, there is no significant difference in progression-free and overall survival, but the median overall survival still tend to increase in optimal cytoreduction group. If we have more population, our research would have been similar to the previous study. In conclusion, our preoperative predictive score and reproducible non-invasive investigation and convenient to use in daily practice, we do not suggest to operate on patients who receive high-risk score for suboptimal cytoreduction. There is no significant difference between optimal and suboptimal cytoreduction in the survival group. The limitation of our study was its retrospective design and small population size, which making it harder to validate the score. Our stand where we use single-center cohort to minimize bias and confounder factor. Additionally, our institution has gynecologic oncologists who have experience of working more than 5 years. Thank you, Colonel Kisnamon Lithirichai, for being a great advisor and other staff member. Thank you for listening. If you have any question, please feel free to ask.
But unfortunately, we don't have time for questions. But I'd like to mention that the rate of optimal cytoreductive surgery is quite impressive in this study. So thank you very much, Dr. Pathamaporn.
Thank you.
And now I'd like to invite Dr. Anyavi Apichotiwat from Chiang Mai University as a next presenter, please.
Good morning, everybody. My name is Anyavi Apichotiwat from Faculty of Medicine in Chiang Mai University. The topic of my presentation today is treatment patterns and surgical outcomes of stage 1A1 cervical carcinoma. Nowadays, due to cervical cancer screening program, the proportion of early stage cervical cancer is increasing. The definition of stage 1A1 cervical carcinoma by FIGO 2009 is shown in the picture. This stage had no standard consensus of the optimal treatment. The prognostic factors such as LVSI cell type may affect the decision of the treatment pattern. The greatest impact factor of survival is lymph node metastasis. 2019 NCCN guideline and 2018 FIGO guideline suggest the treatment for stage 1A1 cervical cancer range from colonization to modified radical hysterectomy, which depend on LVSI status. However, the problem is variation of radicality of treatment that may lead to morbidity of the patients. Previous studies suggest that less radical surgery may be considered because of very low risk of parametrial invasion, or colonization may be performed regardless of margin status or LVSI. So the objective of our study is to evaluate treatment patterns and surgical outcomes of patients with stage 1A1 cervical cancer. This is a retrospective analysis of patients with stage 1A1 cervical cancer who was diagnosed from January 2001 to June 2018 at Chiang Mai University Hospital. All histopathological reports were reviewed by gynecologic pathology specialists. All previously untreated non-pregnant patients with stage 1A1 cervical cancer and no recurrent cervical cancer or other gynecologic malignancies were eligible for this study. The treatment methods were divided into 3 options. First, conservative treatment by colonization. Second, hysterectomy with classified in 3 types as shown. And third, radiation. Pelvic lymph node dissection or sampling depended on surgeon discretion. The outcome of our study is to observe the disease-free survival and overall survival. The statistical analysis of this study as shown in this slide. 185 patients were included in the study. 57% were performed simple hysterectomy followed by modified radical hysterectomy and radical hysterectomy. The mean age of the study group was 45 years old. The most common histologic cell type was squamous cell carcinoma followed by adenocarcinoma. 12 cases had positive LVSI status. Lymph node dissection was performed in 62 patients, but only 1 patient had lymph node metastasis in obturator fossa in modified radical hysterectomy group. No pyramidal involvement was found, and 1 patient in simple hysterectomy group had vaginal margin invasion of cancer, who was treated with laser vaporization. There were no serious complications among patients. However, acute febrile morbidity and lymphedema were significantly higher in modified radical hysterectomy and radical hysterectomy group. The median follow-up time was 40 months. The 5-year disease-free survival rate was 99% and the 5-year overall survival rate was 95%, which was not significantly different between groups. About discussion. Survival outcome of patients with stage 1A1 cervical cancer were excellent. Our study showed that survival outcomes were comparable between radical surgery and simple hysterectomy group. No pyramidal invasion was detected in the hysterectomy specimens. The results were comparable with previous study by Wright et al. The conservative treatment with colonization is a reasonable option for young women desiring future fertility. According to histologic cell type of tumor, adenocarcinoma of stage 1A1 cervical cancer is believed to have poorer prognosis than squamous cell carcinoma. So conservative treatment for microinvasive adenocarcinoma remain controversial. In this study, the survival outcome was not significantly different between both cell types. A previous study by Benedette found that the risk of nodal metastasis was high at 2.6% in LVSI positive patients and to 0.3% in LVSI negative case. But pelvic lymphadenectomy may cause persistent morbidity to patients. In our study, we found only 1 patient had lymph node metastasis despite of negative LVSI. Some previous study suggest that there is no node metastasis was found in stage 1A1 cervical cancer with regardless of the LVSI status. So our study, the strength of our study it is single institution with high number of patients and all pathologic reports were reviewed by expert gynecologic pathologists. The weakness of our study are the bias of treatment method due to physician preference and some medical data may missing. In conclusion, stage 1A1 cervical cancer patients can be treated with conservative surgery due to rare pyramidal involvement and lymph node metastasis. This group of patients had excellent survival outcome. Thank you.
Thank you very much. We are happy to take one quick question, please. Professor Karun, please. Professor Peter Pong, please. Yes.
Not professor.
Yes.
What is the bad prognostic factor for the patient with lymph node metastasis? It is adenocarcinoma or whatever.
In our study, we found only one case with lymph node metastasis in this stage. So this case, this performed by simple hysterectomy, but this case there is no LVSI and it's squamous cell carcinoma. So the number is too small to characterize what is the worst prognostic factor in this case.
The width of the tumor, how long? The depth is quite not depth, but how long or whatever, or you cannot remember. So,
sorry. Thank you for the question.
Yes, Ajahn Karun, please.
Thank you for the interesting paper. What is the definition of modified radical hysterectomy in your study?
In this study, we use Kuromonro classification for type B. It's a modified radical hysterectomy.
Can you describe that?
Modified radical hysterectomy, we use the definition with the
I mean, what did you do for the modified radical?
In this study,
Yes, in this study.
medical chart review. So we
What about the amount of parametrial
yes.
vaginal cuff removed during the usual modified radical hysterectomy method in this study? So how much parametrium and vaginal wall removed? So it's hard to tell because sometimes it depends on the surgeon preference. But usually, for modified radical hysterectomy, we remove about half of the parametrium and about 1 to 2 centimeter of the vaginal fornix, along with the
Because
radical hysterectomy.
it's basically should be cited in your paper that what is the definition of such and such. In order to clarify to the reader.
Yeah, that's a very important point too. So this would be comparable to what we call the type B radical hysterectomy, according to Curlew-Morrow classification. So thank you very much, Dr. Anyavi, for your nice presentations. I'd like to invite Dr. Rutira Manorom Patharasan from Chulalongkorn Hospital, please.
Good morning, ladies and gentlemen. My name is Rutila Manorom Patharasan. Today I am pleased to present about my research, clinical characteristic, prognosis factor, and overall survival of uterine sarcoma patients in King Chulalongkorn Memorial Hospital during 2002 to 2019. Uterine sarcoma is rare, which could be found 1 to 3% of gynecological cancer. They consist of leiomyosarcoma, endometrial stromal sarcoma, and carcinosarcoma. They are an aggressive and poor prognosis tumor. There is few data and a lot of controversy about uterine sarcoma, especially in Asia. So we decided this study to identify disease-free survival, overall survival and prognosis factor of uterine sarcoma. The primary outcome is to identify overall survival in uterine sarcoma. The secondary outcome is to study disease-free survival, clinical characteristic, and prognosis factor. This study is retrospective study. The population is women received treatment at King Chulalongkorn Memorial Hospital who diagnosed uterine sarcoma between January 2002 to December 2019. The inclusion criteria are the patient diagnosed LMS, CS, and ESS. The data collected is based on ICD-10 and pathologic specimen must available for review process to confirm the diagnosis. The exclusion criteria are patients with insufficient data from medical record and no specimen from pathologic review. Sample size was calculated from this formula. Sample size is 92 in this study. We have 114 cases from medical record and 12 cases was excluded due to insufficient data. Finally, there are 102 cases in this study. They are consist of ESS 10%, LMS 33%, and CS 55%. The statistical analysis used in this study was shown in this slide. For the results, the table shows patient characteristics. You can see that mean of age in our study was 56, and in carcinosarcoma, mean age was 60.5 years, which is oldest in 3 groups. The most common presenting symptom is postmenopausal bleeding. Preoperative endometrial biopsy was mostly done in carcinosarcoma, and the result is malignancy 97%. Table 2 presents surgical treatment and pathologic characteristics. The most common FIGO state was stage 1. The most common adjuvant treatment was chemotherapy. The second was radiation. You can see the recurrence of disease was 42%. The most common site of recurrence is pelvic organ in local recurrence and lung in distant metastasis. This table shows disease-free survival of patients. The 5-year disease-free survival was 62% in total uterine sarcoma, and in ESS group, disease-free survival was 70%, which is the longest in 3 groups. The 10-year disease-free survival was 45% in total uterine sarcoma. This table shows overall survival. 5-year overall survival was 40%, and the longest overall survival was ESS, followed by LMS and CS. There was no significance between each histological subtype. The 10-year overall survival was 32% in total uterine sarcoma. This graph shows Kaplan-Meier curve of disease-free survival and overall survival. The longest median survival time was ESS, which was 8.9 years. The shortest median time was carcinosarcoma, which was 1.2 years. This table shows prognosis factor that's statistically significant for overall survival of LMS. We found advanced state, pelvic lymph node positive, para-aortic node positive, LVSI positive, receiving chemotherapy was statistically significant prognosis factor for disease-free survival in LMS patients. After multivariate analysis, there was no significant prognosis factor for disease-free survival in LMS. This table shows unique variate analysis of overall survival of uterine of LMS. The prognosis factor that's statistically significant was shown in this slide, but after multivariate analysis, there was no significant prognosis factor. This table shows prognosis factor that's statistically significant for overall survival in carcinosarcoma. The prognosis factors are advanced state, uterine weight more than 400 grams, residual tumor, pelvic lymph node positive, LVSI positive, omental positive, receiving chemotherapy, and receiving radiation. In multivariate analysis, we found only uterine weight more than 400 and receiving radiotherapy were statistically significant prognosis factor for overall survival in carcinosarcoma. The strength of this study is long data collection for 18 years and a large number of patients. The second, we collect the information of patients who lost to follow up by calling the family and confirm their status with the National Health Security Office. The third is 10-year overall survival report. This study still have some limitation due to the study design is a retrospective study. In conclusion, 40% of the patients survive after 5 years. 1/3 still alive at 10 years. The important prognosis factor in our study is uterine weight and receiving radiation in carcinosarcoma. The information from this study would be useful to general gynecologists and gynecologic oncologists to be able to advise the patients about the nature of disease and prognosis of uterine sarcoma. Early detection of small mass and small uterine size should improve the overall survival of the patient. Thank you very much.
Currently, we are behind in terms of time, so I'd like to thank you, Dr. Rutila, so much for presenting to us the very important data from, I think, one of the largest uterine sarcoma database for Thai populations. So thank you very much. For the next presenter, I'd like to invite Dr. Kanitha Bunchuan, please. From Ramathibodi Hospital.
Good morning. My name is Kanitha Bunchuan from Ramathibodi Hospital. Today it is my honor to present you my research entitled Squamous Cell Carcinoma Antigen for Prediction of Recurrent Squamous Cell Carcinoma of Cervix. So, cervical cancer is the second most common diagnosis cancer in women in Thailand. After a primary diagnosis and appropriate treatment, surveillance method aim to detect the disease recurrent as soon as possible. Early detection of disease recurrence may improve the overall survival of the patient. Surveillance process include clinical part and investigation part. Squamous cell carcinoma antigen or SCC antigen is serum tumor marker for squamous cell cancer. In cervical squamous cell cancer, rate of SCC antigen level was reported about 28 to 88%. No specified cutoff has been validated for cervical carcinoma. About 95% of healthy subjects had a SCC antigen value of 1.5 nanogram per milliliter or less. There are some publications about the role of serum SCC antigen and cervical squamous cell carcinoma recurrence. Rising serum SCC antigen often precedes the clinical detection of recurrent disease and was useful in monitoring disease progression in cervical cancer patients. But in Thailand, the data of serum SCC antigen in recurrent cervical squamous cell carcinoma were limited. So in this study, primary objective was to determine the role of serum SCC antigen for predicting the recurrent cervical squamous cell carcinoma. And secondary objective was to identify the best method of recurrent detection, whether a single cutoff value or level of difference between serum SCC antigen after complete remission and at the time of recurrence. Inclusion criteria were patients with pathologic documentation of cervical squamous cell cancer who had achieved complete response after primary treatment and follow-up in Ramathibodi Hospital between 2012 and 2018. Patients with available serum SCC data at the time of disease diagnosis, complete response, and recurrent diagnosis. Exclusion criteria were patients with chronic liver disease, renal disease, benign lesion of lung or skin cancer, skin disease, and patients with history of other malignancy or pregnancy. After IRB approval, all patients with cervical squamous cell carcinoma from 2012 2012 to 2018 will be retrospective review, and data of disease such as fecal state, tumor size, self-recurrent disease-free interval were correct, and serum HCC antigen were also correct. Pearson chi-square official XX test and student t-test or Mann-Whitney-U test were utilized to compare between patients with recurrent and non-recurrent. The diagnostic performance of serum HCC antigen level will be presented by ROC curve. The cutoff value of each formula was estimated by the point of likelihood ratio positive for each distinct value from ROC curve at 5 and 10. Next are the results. 92% were included with 78 cases of recurrence. Median follow-up time was 3 years and mean age about 57 years. Most of the patients had a stage 2 and 3. And median pre-treatment serum HCC antigen was 5.4 nanogram per milliliter. Post-treatment serum HCC antigen was 2.9 nanogram, 0.9 nanogram per milliliter, and serum HCC at the recurrent was 4.7 nanogram per milliliter. Advanced stage disease, pre-treatment and post-treatment serum HCC antigen were associated with recurrence. Multivariate analysis showed that serum HCC antigen at time of recurrence was independent factor for recurrence. Cut-off value of serum HCC antigen at the recurrence was 2 nanogram per milliliter. The difference of HCC antigen between recurrence and clinical complete response was 1 nanogram per milliliter, and ratio between recurrent and clinical complete response was 2.1 nanogram per milliliter. And C statistic was not different between three formula of serum HCC antigen cut-off value. But discussion result of the study show that patients with recurrent had higher pre and post treatment serum HCC level than those without recurrent. Some previous study that show in this table had high pre and post treatment serum HCC antigen as our study. And the optimum serum HCC antigen at the time of recurrence is more than 2 nanogram per milliliter. In previous study show that 75% of recurrent patients has serum HCC more than 2 nanogram per milliliter, like our study. And the cutoff value of difference between recurrent and the time of clinical complete response was 1 nanogram per milliliter. Result is similar to the previous study. And the cutoff value of ratio between recurrent and at the time and the time of clinical complete response was 2.1 nanogram per milliliter. Three formula of serum HCC antigen cutoff value as previously mentioned can be used equally in cervical cancer surveillance. There were some limitations of this study to be mentioned. First, it is a retrospective study which includes patients from the single institute that our finding may not be proper for the other setting. There were approximate 50% for missing data, and tissue biopsy was not available in all cases when recurrent was diagnosed. The evidence of disease recurrent diagnosis in this study was dependent on radiologic imaging. The PET-CT scan had been performed in very few cases. For the future study prospective design, large-scale study should be conducted from multi-center setting. Long-term follow-up time will provide more information of serum HCC antigen for screening of recurrent cervical squamous cell carcinoma. In conclusion, serum HCC antigen value at the time of recurrence not only the single value, but also different or ratio with the time of complete response demonstrate an excellent diagnosis performance for prediction recurrent squamous cell carcinoma. Thank you.
Thank you very much. Unfortunately, we don't have no time at all for the questions on this study. So thank you very much for your nice presentations. I'd like to invite the next presenter, Dr. Nichapon Sangwandikun, also from Ramathibodi Hospital, please.
Okay. Good morning, everyone. My name is Nichapon Sangwandikun. Today, I'm going to present my research titled, Can Cancer Antigen 125 Carcinoma Embryonic Antigen Ratio be used in detection of epithelium ovarian cancer? As for the ovarian cancer, it's the 8th most common female cancer in 2018 from Global Can 2018, and it's a 9th most common death of cancer in female in 2018. As for in Thailand, ovarian cancer is the 6th most common of female cancer in 2012, and more than 70% of patients was diagnosed late state of disease. So, in recent decades, tumor marker has been studied for preoperative prediction and for also the diagnosis for epithelium ovarian cancers. So, cancer antigen 125 or CA125 is the most widespreading marker for epithelium ovarian cancer, but it's also rise false positive in many conditions. As for CEA, is related to GI cancer, breast cancer, and so also ovarian cancer. So lately there's many studies that use the ratio to improve the sensitivity and also specificity. However, the data in Thailand, the data also limit, and it also haven't been studied in Thailand too. So the objective is to study the ability of CA125 CEA ratio, or I will call it CCR, to differentiate between benign and malignant ovarian tumor. And the secondary objective is to establish its optimal cut-off value and also test the diagnosis performance of CCR. So the method, after they have approved from IRB, all the medical record of patient with ovarian tumor who's undergo primary surgery at a Ramathibodi Hospital from 2009 to 2018 were retrospectively reviewed. The data was collected. The patient inclusion is the patient who had post-operative pathological document and had a preoperative serial marker, CA125 and CEA, up to 3 months prior to surgery. And exclusion criteria was pregnancy, breastfeeding, and also patient who had previously diagnosis of other malignancy or non-epithelium ovarian cancer, and also an incomplete medical record. This is a lab method for the CA125 and CEA. After collect the data, the statistical analysis was done. And as for the diagnosis, performance was analyzed by C-statistic. And for the sensitivity, specificity, and PV, and optimal cut points were analyzed and compared with ROC curve. And the cutoff value was selected by positive likelihood ratio and Uden index. The results. The patient that review is about 6,000, but about 5,000 has incomplete data. So it's only left about 861 cases, and about 315 were excluded by malignancy. So at last we had epithelial ovarian cancer about 140, borderline ovarian tumor 28, and benign 378. This is patient characteristic. The significant difference in age. As you can see that epithelial ovarian cancer in our study have about 70% in early stage. As for the level, according to the pathology outcome, you can see the difference in all three groups in CA125 and also the CCR, which is significant. After that, the value was analyzed. As I told before, the cutoff value were the 20 is the cutoff value which derived from the positive likelihood ratio, and 29 was calculated from Uden index. When compared to the ROC curve, it can be discriminate the epithelium ovarian cancer from the benign ovarian tumor, which sensitivity and specificity was shown in this slide. But both of value was no statistical significant. But for CCR for borderline ovarian tumor is failed to discriminate both from cancer and from benign. As I told before, the patient population is mostly in early stage, which is not like before study. This contradiction finding might result from the retrospective nature of our study, which excludes many patients from inadequate data from tumor markers. And for the cutoff value of CCR, it was either 20 or 29, but no statistical difference. So we prefer to suggest the cutoff value of 20, which slightly higher sensitivity from 29. As we compare to the previous study, which sensitivity was about 75 to 87, and specificity about 74 to 80, which cutoff value about 20 to 25, which is slightly lower. This might because our study has mostly in stage 1, and the histopathology in mucinous was a little bit higher. The strength of this study is the first study in Thailand, and even though it excludes many population, but it still have a large sample size, and it had a similar laboratory method due to the single setting study. The weakness, as I've told before, it is a retrospective study which had a selective bias. So, conclusion, CCR can be used as one of the two in differentiation of epithelial ovarian cancer from benign ovarian tumor. And the most common cutoff value is 20, which result is in the sensitivity and specificity of 77.9 and 61%. Thank you.
I wish we have more time for questions, but we don't. So we have to move on. I would like to thank Dr. Nichaporn so much for her presentations. So we are going to invite the last, but of course not least, presenter for today's sessions, which is Dr. Nitya Intikut from Siriraj Hospitals. Dr. Nitya will present the very interesting study comparing the oncological outcome between laparoscopic and open radical hysterectomy for early stage cervical cancer.
Good morning, ladies and gentlemen. My name is Nitya Intikut from Silat Hospital. Today, I would like to present my research in the topic of a retrospective comparison of the oncologic outcomes between laparoscopic and transabdominal radical hysterectomy with pelvic lymphadenectomy in early-stage cervical cancer patients. Cervical cancer is the fourth most common cancer in the world and the second cause of death in Thailand. The average mortality rate was 9 cases a day. According to National Comprehensive Cancer Center Network, radical hysterectomy with bilateral pelvic lymph node dissection is preferred treatment for fecal stage 1A2 to 2A lesion when fertility preserve is not desired. Several retrospective studies show no significant differences in survival outcomes between transabdominal and laparoscopic surgery. Laparoscopic radical hysterectomy with pelvic lymphadenectomy was firstly introduced in Silat Hospital since 1995. LACC trial, a prospective randomized trial, showed that minimally invasive approach was associated with lower rate of overall survival than transabdominal surgery. This study would like to evaluate outcome of laparoscopic radical hysterectomy in Silat Hospital. Primary objective was to compare 2-year disease-free survival between laparoscopic and transabdominal surgery in patients with early-stage cervical cancer. The secondary objectives were to compare 2 years overall survival, surgical and pathological outcomes. The study design was retrospective study. The sample size was calculated using non-inferiority based on data of previous study. When the calculated sample size was 82 in laparoscopic group and 163 in transabdominal group. Descriptive statistics were analyzed by chi-square test, Fisher-Exact test, independent t-test, and many witness test. Data are shown as number and percentage, mean with standard deviation range, or median and range. P-value less than 0.05 was considered statistically significant. A total of 263 patients underwent radical hysterectomy with pelvic lymphadenectomy for early-stage cervical cancer. Patients were matched using age and tumor size to control the selection bias and confounding factor. No conversion from laparoscopic to transabdominal surgery in our study. Baseline characteristics were similar in both groups. Median time of follow-up was 80 months in laparoscopic group and 84 months in transabdominal group. 2-year disease-free survival rate were 92% in laparoscopic group and 96% in transabdominal group. The log length test showed no statistically significant difference. 2 years overall survival was 97% in laparoscopic group and 99% in transabdominal group. The log length test showed no statistically significant difference. Mean operative time in laparoscopic group was longer than in transabdominal group. Residual urine of 100 ml or less was found in 40% of laparoscopic group, whereas 53% in transabdominal group. Intraoperative and postoperative complications were not statistically significant difference in both groups, but laparoscopic group had less blood loss than transabdominal group. Recurrent disease was not statistically significant difference in both groups. From previous study, Laparoscopic group has longer operative time and short hospital stay. In our study, laparoscopic group has significant longer operative time, and postoperative hospital stay was similar in both groups. The patient in our study should usually stay in hospital until 7 days for trying to remove Foley catheter. Our study showed no statistically significant difference in lymph node yield, rate of lymph node metastasis, area of parametrium retrieved, length of vaginal cuff. This might translate that the adequacy of surgery of both methods was not different in our study. In our study, intraoperative complications were 13% in laparoscopic group and 20% in transabdominal group. P-value was 0.17. Postoperative complications were 8% in laparoscopic group and 4% in transabdominal group. P-value was 0.16. The results were compatible with previous study. Several studies show that survival outcome was similar between two groups. But Ramirez study showed that minimal invasive surgery was associated with lower rate of overall survival. In our study, disease-free survival and overall survival was not statistically significant difference between two groups. Variation in technique and expertise might be occur and result in poorer outcome in multi-center study. In Canal study, the study show the patient 80 patients who undergoing laparoscopic surgery and 84 patients who undergo transabdominal surgery. The data show that the technique with no look, no touch technique Variation in technique and expertise might be occur and result in poorer outcome in multi-center study. Canal study, a retrospective study of 80 patients undergoing laparoscopic surgery with no look, no touch technique, and 83 patients undergoing transabdominal surgery, show oncologic outcome were similar between two groups. Data suggest that tumor cells spillage into peritoneal cavity might result in poorer outcome. And crossing vaginal technique and abandoned uterine manipulator might make the outcome better. The strength of this study include the large sample size in the single institute with matched patient to prevent selection bias and confounding factor. The limitation of this study is the retrospective nature. So, conclusion in this study, 2 years disease-free survival and 2 years overall survival were not statistically significant difference between laparoscopic and transabdominal surgery. The patient should be concerned about the risk and benefit of this approach. Thank you for your attention.
Thank you very much. I think your data will provide a very important basic foundation for our future discussion about the root of radical hysterectomy. open versus laparoscopy, which will be organized by the TESCO committee on December the 2nd this year. So please stay tuned to more information about the meeting. So I'd like to thank Dr. Nitya a lot for your nice presentations. Thank you very much. And I'd like to apologize for the delay in terms of the schedule because many questions are too important to skip. So I'd like, on behalf of the Scientific Program Committee and the Fellowship Training Committee, I'd like to congratulate all the presenters for their success in conducting the fellowship research. And we wish all of you all the best in your future career. So thank you very much. So this is the conclusion of this morning session. Thank you very much for your attention.